Today, I will discuss the clinical presentation of renal or ureteric stones, a topic often tested in exams like PLAB 1. The classic presentation is called renal colic, which is caused by the obstruction of the ureter. Patients will experience acute, severe, spasmodic pain that starts in the loin or flank and radiates down towards the groin and, in men, to the testicle. A key feature is that these patients are typically restless and unable to sit still, which helps distinguish stone pain from conditions like peritonitis. Other associated symptoms include hematuria, which is blood in the urine, dysuria, nausea, and vomiting. A key PLABable tip is that pain with hematuria is more likely to be stones. In contrast, painless hematuria in a patient over 45 years of age warrants urgent urology referral to rule out urological cancer, such as bladder or renal cancer. There are several common risk factors that predispose people to forming stones. These include dehydration, which concentrates the urine, certain medical conditions like gout and hyperparathyroidism, and a genetic condition called cystinuria. Anatomical abnormalities in the urinary tract, such as ureteric strictures or horseshoe kidneys, can also predispose people to stones. These are all points to remember for the PLAB exam. Moving on to investigations, the initial test of choice for a non-pregnant patient with renal colic is a non-contrast computed tomography scan, or NCCT, of the kidneys, ureters, and bladder, often called an NCCT-KUB. However, in pregnancy, an ultrasound of the whole abdomen, or USKUB, is preferred to avoid radiation exposure to the fetus. Ultrasound can identify hydronephrosis, the stone itself, and other potential pathologies. When managing the acute pain of renal colic, the first-line treatment is nonsteroidal anti-inflammatory drugs, or NSAIDs, such as diclofenac, which can be given orally, rectally, or parenterally. NSAIDs are generally considered the first line for ureteric colic. If NSAIDs are contraindicated or ineffective, intravenous paracetamol can be given. If still ineffective or contraindicated, opioids such as tramadol can be used. It is important to note that antispasmodics should generally not be offered. Urgent decompression is required for complicated stones, specifically when there is an obstructed collecting system with fever or sepsis, or with acute kidney injury, or if the patient has a single functioning kidney and hydronephrosis. The management options for decompression are ureteric stent, also known as a JJ stent, which is a tube inserted from the kidney to the bladder, or percutaneous nephrostomy, or PCN, where a tube is inserted directly into the kidney through the skin on the back. For definitive management, stones that are less than 5 millimeters in size are generally managed non-surgically with increased fluid intake, as they tend to pass spontaneously. Stones between 5 to 10 millimeters, located in the distal ureter, can be managed with medical expulsive therapy, often with alpha blockers such as tamsulosin. For stones 5 to 10 millimeters, located in the upper ureter or in the kidney, extracorporeal shockwave lithotripsy, or ESWL, is preferred. Ureteroscopy is typically used for stones between 5 to 20 millimeters. For stones larger than 20 millimeters, percutaneous nephrolithotomy, or PCN, is the surgical treatment of choice.